In this video, we'll be discussing key documentation changes that impact the integumentary and musculoskeletal systems. This will be the meatiest video in the series since there are a lot of changes in ICD-10 specific to these organ systems. In a recent audit of all EGO clients over a 6-month period, integumentary diagnosis codes accounted for 4 of the top 50 diagnosis codes, totaling 5% of all top 50. We will discuss these commonly reported codes in addition to some other major changes relevant in the ED setting. Some key concepts in this section will be anatomic specificity, causal information, and laterality when appropriate. There are some major changes in ICD-10 related to coding of wounds. In ICD-9, any injury that is considered an open wound is classified simply as an open wound. In ICD-10, this is further broken down by type to lacerations, puncture wounds, open bites, and the hopefully avoidable unspecified open wound. Some commonality exists in how open wounds are categorized. The first area is the type of wound, and the second is the site with some level of description including laterality and presence or absence of a foreign body. Lastly, the coder will be looking for information to indicate if this is an initial, subsequent, or sequela encounter. As a brief refresher on the extension codes, initial encounter is used when the patient is receiving active treatment, and most instances in the ED will fall into this category. Subsequent encounter is used when the active treatment is complete and the patient is returning for routine care, for example, suture removal or wound check. Sequela is used when complications or conditions arise as a result of a condition, for example, a post-procedure abscess. For example, 3 basic finger laceration codes in ICD-9 expand to 153 code options in ICD-10. While this seems alarming, many of those options just have to do with what type of wound and which finger. To avoid an unspecified code, the documentation would need to support if there was also damage to the nail. Since this is a commonly coded ED scenario, many EMRs will likely be modifying the physical exam or procedure note section to capture this level of detail if they haven't done so already. If you're using a homegrown template, consider adapting to include this information if not already documented. There is little change to how cellulitis is reported, except to include laterality when appropriate. For example, cellulitis of right lower limb would be coded as L03.115. If documenting pressure ulcers, the location and stage of ulcer are important. It is likely this will be relevant for admitted patients. Musculoskeletal diagnosis codes accounted for 5 of the top 50 diagnosis codes, totaling 8% of all top 50 coded in EGO over a 6-month period. There are significant changes for coding musculoskeletal conditions. To put it into perspective, 34,250 of the roughly 70,000 ICD-10 codes can be accounted for by musculoskeletal conditions. The key here really is the level of anatomic specificity and laterality descriptors. Since the first 2 musculoskeletal codes to show up in our top 50 are leg pain and lumbago, let's start with a brief discussion about coding requirements for pain in general. Since ED providers often see and treat patients for pain of unknown origin, it is acceptable to report pain diagnostic codes. Coding for pain in ICD-10 is categorized by specific site and laterality of the pain. An example would be pain in lower leg, or M79.66. If the underlying cause of pain has been identified during the encounter, this should also be documented as a clinical impression. ICD-10 distinguishes between sprains and strains, and if you know the associated muscle, tendon, or ligament involved, document it since this would avoid an unspecified code. At a minimum, include the location and laterality to avoid a completely unspecified code. Fracture codes account for 25% of the 70,000 codes available in ICD-10. And to break it down even further, laterality descriptors account for almost 11,000 or 62% of that 25%, so documenting if the fracture is left, right, or bilateral is extremely important. In addition to laterality, the anatomic location, type, and stage of healing with any associated complications should also be documented. Since most EDs do not provide subsequent or follow-up care for fractures, initial encounter would be the appropriate encounter selection. Open fractures are detailed to include the Gustillo classification. The categories, as outlined on the slide, are 1 through 3, with 3 being the most serious. To assign a dislocation code in ICD-10 to the highest level of specificity, be sure to include the extent of dislocation and position when appropriate. For example, an anterior partial dislocation of right humerus would be coded as 43.011A, with the A added to reflect the initial encounter. To assign a hernia code in ICD-10 to the highest level of specificity, be sure to include the type or location, laterality, recurrence, and presence or absence of gangrene and/or obstruction. If the type and contributing factors for osteomyelitis are known, include that in your documentation, but it's likely that that will not be available during the ED encounter. At a minimum, include affected area, laterality, and if acute or chronic. Thanks for taking the time to watch this short video. For any questions, please contact me directly or Jim Blakeman, Senior Vice President at Emergency Group's office.